Hello, you're watching sqadia.com, and today our lecture topic is infections, and we on the fifth subsection of it, that is the acute suppurative arthritis. In this section, we'll be going through the general aspect of acute suppurative arthritis, its clinical features, and how to make a diagnosis of acute suppurative arthritis. What are the differentials we should be considering when we're dealing with acute suppurative arthritis, and treatment of acute suppurative arthritis. If you see general aspects, although it's a very rare disease and mainly usually affects children, but if it has infected, it's highly debilitating because it can create a kind of a permanent disability which is most likely lifelong. If the child can have a like ankylosis of the knee due to suppurative arthritis at the age of, let's suppose, 6 or 8 years, he or she may have to live for next, let's see, 60, 70 years, and then he has to carry the problem for whole of his or her life. So although it's rare, but if it occurs, it's something which is an emergency. It has to be dealt properly because morbidity of this disease is very high. Joint can become infected through direct invasion, through a penetrating wound. A child was playing and got some kind of a penetrating injury to his or her knee. Probably this most likely area are usually, it could be intra-articular injection or arthroscopy. Usually intra-articular injections, needles are sterile, but if there was some kind of a breach in the hypodermic needle, this can predispose them to infection. There could be a direct spread from adjacent bone abscess. As you know that in children, the periosteal blood supply is such that the metaphyseal arteries have connection with the epiphyseal one, and there is an anastomosis in between them. So if the initial infection was in the metaphyseal part, this will spread eventually through the physis into the epiphyseal part, and then eventually into the joint. So joint can be infected through osteomyelitis or adjacent area. This could spread through blood from a distant side, as it occurs in the case of acute haematogenous osteomyelitis. That although there was a sore throat or some kind of in female, especially if there was piercing of ear, there was some kind of focus which was very much distanced away from the bone, but actually the microorganisms have spread via bloodstream into the area. Now coming to the microbiology, what type of organisms are involved? The common organisms include Staphylococcus aureus, and I've been talking about it that it's the most notorious. Almost every type of infection, the first and foremost organism you should be thinking about is Staph aureus. Then it's H influenza, especially in those children who do not get vaccinated or those are living in those parts where the vaccination program is not that effective, that each and every child gets vaccinated for H influenza at 9 months of age. Then that could be Streptococcus, E. coli, a Proteus species, mirabilis. Now coming to the pathology, if you see, this is the diagram of a knee joint. Usually a trigger is haematogenous infection, which settles in the synovial membrane. Once it settles down, it starts inflammation of the synovial membrane. Once synovial membrane gets inflamed, there's increased synovitis, increased exudate formation, and there is a lot of edema formation in the joint. An acute inflammatory reaction with a serious and seropurulent exudate and an increase in the synovial fluid. Once that happens, the next stage is, as the pus appears in the joint, articular cartilage gets eroded. Now, over here you can appreciate that articular cartilage started to get eroded. And as the joints start to get involved, first the articular cartilage goes, and then once the articular cartilage is gone, the bone underneath gets exposed. And this is kind of a time when usually ankylosis would eventually start. And once the bone gets exposed, as you can appreciate over here, that eventually ankylosis of the joint would occur, that bone would fused, as there is no in between present, and once ankylosis has occurred, there is actually no range of motion. And for example, a patient can have a knee which could be in extended or in 20-degree flexion or extension contracture, and this kind of inflection extension contracture, if knee gets ankylosed, for that child to walk for lifelong would be practically impossible. So it's kind of a highly debilitating disease if it gets kind of a progressed over many weeks, or if it's not checked properly. In neonates, usually they usually do not actually present with more of the features. It's very difficult to actually diagnose whether it's Haematogenous osteomyelitis, or it is toxemia, or it is actually an arthritis. But the usual picture is actually newborn infants' emphasis on septicemia rather than joint pain. Baby is irritable and refuses to feed. Rapid pulse and sometimes a fever. Joints should be carefully felt and moved to elicit local signs of warmth, tenderness, and resistance to movement. And whenever there will be inflammation, there will be definitely swelling, there will be redness, there will be warmth or heat, and there will be loss of motion and painful. And usually, in clinical settings, we look for what is the focus of infection, where would be the initial focus was. Was it in the joint? Was it adjacent to the joint, or was it for somewhere a distance area where actually the infection is spread via bloodstream? Now, coming to the clinical features of the acute suppurative arthritis in children, as this you can appreciate it over here. This is looks like a normal knee, but if you see it over here, there's a lot of swelling. Look at the tibia; it's kind of showing a fraying area as well, and similarly, almost the distal femur is also showing some signs of inflammation. Acute pain in a single large joint, commonly hip or knee, as hip and knee are most commonly affected. Reluctance to move the limb or affected joint. Overlying skin looks red, and a superficial joint swelling may be obvious. Local warmth and marked tenderness. All movements are restricted and often completely abolished by pain and spasm of the muscles. Now, in adults, there may be suppurative arthritis would be different. Although almost the picture is same, but in sometimes usually we know that the course is slightly more chronic as compared to the children. In adults, it's often superficial joint, knee, wrist, finger, ankle, or toe that is painfully swollen and inflamed. And over here, you can see an MRI. It's basically a T1 image. As you can appreciate over here, the exudates appear black, or water is appearing black. So this is the most likely the sequestrum, the bone, dead bone which is there, and new bone formation is going to be taking place along with it. And there is some degree of edema, swelling of the soft tissue as well, which can be appreciated over here. And once this in the metaphyseal area it has started, is actually spread through, and I cannot appreciate over here any epiphyseal line, and it's going into the physis. There is warmth and marked local tenderness. Movements are restricted at the affected joint. Patient with rheumatoid arthritis, and especially those on steroid treatment, will develop a swollen joint infection. That they may have acute arthritis, but they're not really worried about it, or they really don't know about it. Coming when we will be examining a patient with acute suppurative arthritis, when you see suppuration means pus, definitely there will be a lot of swelling, and when we aspirate, the pus would always be present. So coming to the labs, the first thing we have to get is an ultrasound, because most ultrasound is the most reliable method for revealing a joint effusion in early cases. And we can use, if in early case times there will be marked less swelling, there will be very less exudate or suppurative pus. Now, if we can localize it and take it out, we will know that what type of an organism it is, and we can start the antibiotic early. And later on, if once the whole of the joint is involved and there is a lot of swelling and a lot of pus, and there we can simply, without the use of ultrasound, and we can put the needle in and take out the aspirate so that the organisms can be cultured. The next are the X-rays. X-ray is usually normal early, but signs to be watched are soft tissue swelling, loss of tissue planes, widening of the radiographic joint space, and slight subluxation due to fluid. Radionuclide, a bone scan, has to be done for infection, and that's always indium labeled 131. Then MRI would show the exudates, edema of the soft tissue, and there may be a soft tissue necrosis or what kind of things such as that kind, actually that would be depicted on MRI. Coming to the labs, it's always the blood CP that would usually show acute infection, There will be raised TLC. At times there will be 20,000, 30,000 the TLC level. Neutrophils will be markedly raised. ESR will be markedly raised. There will definitely rise in CRP. Then on the cultures, if we get in, usually will be seeing an organism which will be present on the cultures. And blood cultures are really needed because its suppurative arthritis is usually such a exudative pus is present that pus can easily be isolated and the cultures for the organisms can be done. Coming to the differential diagnosis, if let's suppose a child comes to you with a history of 3 to 4 days of knee pain, swelling, is febrile, he's also has a fever, let's say low grade fever of 1 or 2 episodes, and when you examine the knee, there is definitely swelling, there is redness, there's warmth, and child is quite irritable. When you try to move the limb and the knee flex extend, it's actually quite painful. So what are the differential diagnoses in such cases? This despite acute suppurative arthritis, this will include acute osteomyelitis. This could be simply traumatic, irritable joint synovitis, hemophilic bleed. Hemophilic patients sometimes they present with sort of tumors that there is so much bleed into the joint that once this hematoma which has formed actually gets secondarily infected. So although there are signs of infection, but actually the cause was kind of initially the hematoma which was due to the bleeding and actually has got now become secondarily infected. It could be juvenile rheumatoid arthritis. It could be in case of hip. It could be psoas or pelvic abscesses, which is actually has trickled down and actually creating discomfort at the hip. But actually, the main involved pathology is lying retroperitoneal in the psoas at the pelvic area. Coming to the treatment, the priority is to aspirate the joint, examine the fluid. Empirical antibiotics are started. If the aspirate looks purulent, the joint should be drained. That is one form, arthrotomy or arthroscopic lavage. The rule is if it's pus is there, you have to drain the pus by either open arthrotomy, by medial lateral parapetal approaches, or by arthroscopic lavage. Then you put in the arthroscopic ports if it's an adult, you wash it thoroughly, well, copious quantity of saline, and you take the samples for the cultures as well. Splint the joint involved in case of usually it affects the children. So if it's knee or hip, it's highly painful. So splinting actually decreases movements of the joint and actually makes it less painful. Analgesia and supportive care is needed if it's for the relief of pain, and supportive care is actually along what else, whether it's associated dehydration or not. If there's some degree of dehydration, that can also be countered by this supportive care. Thank you very much. Keep watching sqadia.com.